Welcome to Medscape. I'm your host, Dr. Andrew Wilner. It's my pleasure today to introduce Dr. Richard Caselli, professor of neurology at the Mayo Clinic and an expert in Alzheimer's disease. Welcome, Dr. Caselli.
Pleasure to be here. Thank you, Dr. Wilner.
Dr. Caselli, as you know, there's been quite a revolution in the treatment landscape of Alzheimer's. First, aducanumab in 2021, and then just a few weeks ago, lecanemab, two monoclonal antibodies, FDA approved for the treatment of Alzheimer's disease. But I've listened to podcasts and I've read about these drugs, and there seems to be a fair amount of controversy that even though they're FDA approved, there's a lot of pros and cons. I need some help to figure out what to do with my Alzheimer patients. And I figured out you were the go-to guy. So what do I do?
Well, I'm happy to share some thoughts. As you correctly point out, there is a fair amount of controversy, probably more than I've seen for anything else in my career in our field regarding these medications. I guess the first thing to point out is both of them, as well as others that are in the pipeline, have been far more effective in moving a biomarker than their predecessors. The biomarker in these studies has been an imaging biomarker, an amyloid PET scan. And it really has been quite remarkable to see the difference between the amount of amyloid in the brains of people with Alzheimer's disease before treatment and the relative reduction and almost depletion of amyloid following treatment. Treatment typically takes a while, I mean, months at a minimum, a year or more at most, or I shouldn't say at most, but not uncommonly. And so it became a type of really human experiment testing the amyloid cascade hypothesis that was formulated in 1991. So for the past 30 years, we've been aiming for this. So what was the outcome of achieving what the amyloid hypothesis predicted would essentially cure Alzheimer's disease? And the answer was it helped a little. Now, a little, you can be a glass is half full or a glass is half empty kind of person. But to give you some specifics, in the aducanumab trial, without going into all the controversy of that, you will recall that initially Biogen, which sponsored those trials, stopped them after doing a futility analysis and concluding that aducanumab was really not clinically effective. They then changed that by having analyzed further data and subdividing their patients into milder cases, and found that in one of the two trials that they were conducting at the time, the patients with the mildest stage disease, meaning mild cognitive impairment and mild dementia, who'd been in the highest dose for the longest time, did actually hit their clinical target that was statistically significant. What that amounted to in terms that many of your viewers might recognize, they had a number of outcome measures, but one that's familiar to many of us is the Folstein Mini-Mental Status Examination. And after about a year and a half, which is unusually long for a trial, but is kind of necessary for these disease modification trials for Alzheimer's disease, the difference between the high dose group and the low dose and placebo group was only about half a point on the Folstein Mini-Mental Status Exam. Now, in the lecanemab trial, there was a little bit less controversy in that there was only one trial that did not have discrepant results like the aducanumab trial. The usual leading soundbite, if you will, when you hear about the benefits of lecanemab was that it slowed disease progression as measured by the CDR sum of boxes by 27%. So what is the CDR sum of boxes, and is 27% meaningful? So CDR stands for Clinical Dementia Rating Scale. It's not something that you do in your office. It's not something I do in my office, although we do it in our research program, as do other research centers. It's really not a test. It's really an interview. It's separate interviews done with the patient and with their informant, typically the spouse. And they're asked questions that are relevant to 6 different domains of functioning, or what are called boxes. memory, judgment and problem solving, home and hobbies, and some others as well. The best you can do in any of these categories is 0. That means there's essentially nothing wrong. The worst you can do in any one of these categories is 3, which means things are severely wrong. And so 3 times 6, which would be the maximum score one could get on the CDR sum of boxes, is 18. The difference in the treatment group and the placebo group in the lecanemab trial was 0.45 at the end of about a year and a half. Now, again, that doesn't sound like a lot to those of us who view the glass as half empty, but to those who view the glass as half full, they say, well, that's 27% reduction in degree of decline compared to the placebo group. Okay, well, when we look at another trial, which you haven't mentioned because it hasn't been in the news, because it hasn't hit its endpoints, was the gantenerumab trial. The gantenerumab trial was another monoclonal antibody directed against amyloid. This one delivered subcutaneously. It performed better in previous studies, but in this particular phase 3 study, in its phase 3 trials, it didn't hit its endpoints. But what does that actually amount to? A difference of 0.31 in one of the 2 trials in the CDR sum of boxes. So here you've got 0.45, p-value less than 0001. Here you've got CDR difference 0.31, p-value is around 0.09. Is that a huge difference? Well, it doesn't sound like a huge difference, absolutely. Now, in addition to the benefit, because look, if this was a little lesser than capsule you could pop in your mouth, I'd say everybody should take it. But it's not. It's an intravenous infusion. Aducanumab was once a month. Lecanemab is every 2 weeks. Another one in the pipeline, donanemab, is once a month. And with both aducanumab and lecanemab, there's no upper limit to the amount of time a person could continue to receive this. It's essentially for as long as somebody would be considered to be at a mild stage. And that could be for a year, it could be for 3 or 4 years. Donanemab is pretty much setting the bar at you're done at 1 year. And one of the thoughts behind that, I suppose, is that it seems to be a little bit more rapid in the clearance of amyloid from the brain. It wouldn't surprise me if at the end of all of this, this becomes kind of a winner take all, in that why would you do something every 2 weeks when you do it once a month? And thinking about gantenerumab for a minute, there are trials looking at subcutaneous versions of some of these things. Why would you do anything intravenously if you could do it subcutaneously at home? So from the administration standpoint, the effectiveness standpoint, those are a couple of big considerations. And finally, I'd be remiss not to mention adverse effects. The way these work, of course, as your viewership knows, is essentially translating it by causing inflammation in the brain. I mean, that's the whole point. You're getting monoclonal antibodies that are binding to amyloid or some point along the pathway and inciting an immune response to clear amyloid from the brain. That is inflammation. In some cases, it's a robust enough inflammation that one can see cerebral edema on an MRI scan of the brain, also called ARIA, or amyloid-related imaging abnormality. In my opinion, a somewhat obfuscatory term that makes it sound like some imaging artifact. It's not an imaging artifact. There's nothing artifactual about it. It is a cerebral edema. And in some patients, it has a hemorrhagic component as well. And the risk involved is very related to a person's ApoE genotype. ApoE homozygotes, who comprise 2% of the general population, but about 10% of the Alzheimer's population, are at lowest risk for benefiting from lecanemab. They actually got worse in the trials, and they're at the highest risk for developing serious adverse events, like I was just mentioning. There are sex differences as well. Men seem to respond much better than women for we don't know what reason. There are age differences. Older people over 65 seem to respond much better than younger people under 65. Over 75 compared to people under 65. Don't really know why. So there are a number of considerations here, not the least of which is cost, which I haven't even mentioned. But that's kind of where we are in terms of, what are the effects these things have? How are they administered? What are the potential benefits and what are the potential risks?
Wow. So I feel really good about myself because this was a great question that I asked, because this is a complicated answer. I want to follow up on just a few of those things. Clinical benefit. That's really the key. You know, when you're sitting in front of the patient and the patient says, "Should I take this medicine?" In their mind, they want to get better, or they want their loved one to get better. Now, there were these statistically significant improvements. Now, I know on the Folstein, I grew up using the Folstein and Folstein, Folstein mini mental status. A half a point from in my hands is within the margin of error of testing. So if it came out that that's the only benefit, that's an answer for me. Now, the trial may have been much more consistent, but a half a point out of 30 is not a whole lot. But what I'd really be interested in, were there any patients who were in a nursing home, for example, that were now able to go home? Or were there any patients who were at home but needed assistance, for example, with activities of daily living that were now independent? That's an endpoint that I think, for me anyway, and my patients, would be very significant. Did they see anything of that magnitude?
Right. The short answer is no. The longer answer is the target patient population for these treatments are people with mild cognitive impairment and mild stage dementia. So these are not the people that you're referring to. Those more severely impaired people, to the extent they were even enrolled in any of these trials, to my knowledge at least, did not demonstrate any significant benefit.
Clarify something for me. In the old days, anyway, when a drug was FDA approved, it meant that there was clinical benefit. But from what I understood, the FDA approval in this drug, and maybe for others, was based on a biomarker. Now, is this a new thing the FDA is doing? Is this something everybody's on board with? That it, like, if the biomarker gets better, then the patient's better, and that's good enough? Is that what's happening here?
Yeah, again, the short answer is yes. The longer answer, I'm not an FDA expert, so I can't speak to how long they've had this program, but it's called the Accelerated Approval Track. Accelerated sounds good, but what it basically means is what you've described, that they're approving something before they're totally convinced that it's clinically beneficial. Again, there's a lot of history behind the amyloid cascade hypothesis and the strategy that led up to these studies and their results. So I imagine between that sort of momentum behind this whole strategy and not to be ignored, the understandable vested interests of groups like the Alzheimer's Association. A lot of people are looking for something. I mean, Alzheimer's disease is probably in a class by itself in terms of the lack of progress that's been made in advancing care. Prior to aducanumab, I mean, the most recently approved drug was memantine, which was, I don't know, 20 years ago, more. I don't remember the exact date, but it's been a long time. And when we look at things like mortality rates in diseases, the mortality rates in heart disease have gone down and cancers have gone down, not so in Alzheimer's disease. So you can understand why the FDA might have been willing to say, give it all the benefit of the doubt. But the idea behind the accelerated approval program is that they're supposed to come back with more data, post-marketing, and Medicare is assisting with that, if you will. Not everybody looks at it as assistance, in that their decision was that they were not going to simply cover the cost of this, except within the context of a further clinical trial. So there are people getting it within the context of a clinical trial, registering results to eventually show or disprove whether this is in fact, helping people.
Oh, well, that helps a lot, because it takes a little of the burden off me. So I don't have to just sit there and say, yeah, I'm going to write this script for you or not. And then you're going to come every 2 weeks. I'm going to do MRIs every 3 to 6 months, and we're going to follow you very closely. Now I can say, well, this is a tricky drug, and I'm going to send you to a center of excellence where, if you really want it, you can enroll in a clinical trial. Is that right?
At the moment, that is correct, and it may stay that way. There has been expressed interest by a number of people in the field petitioning Medicare to reconsider their stance, because when they came out with that statement, which they came out with at the time of aducanumab, they made it more of a blanket statement for all monoclonal antibody therapies directed against amyloid. As you may know, Eisai, who is the primary company behind lecanemab, is also applying for full FDA approval. If they get that, it would put more pressure, obviously, on Medicare to simply offer blanket coverage for that drug. Again, how that will play out, we are still all waiting to see.
I want to follow up on a small point, just from my own information. The way these drugs work is to remove amyloid from the brain. Now, sometimes there's amyloid in the blood vessels themselves. What happens in that situation?
To my knowledge, it does work on the blood vessel based on the amyloid angiopathy component as well. And I believe it's thought that's the likely source of, at a minimum, the microbleeds that I mentioned earlier, the hemorrhagic component of the cerebral edema, and maybe even the cerebral edema itself. I'm not sure if there's more than one source for the edema, but blood vessels would also be a candidate in that regard. But yes, it does also work on blood vessels.
Okay. Well, Dr. Caselli, you have given us a lot of terrific information in a very brief period of time. I want to thank you. Is there anything you'd like to add before we close?
It's been a pleasure to be here. You've asked some very good questions, and as you can tell, we're all challenged by this. This is not going to be easy for anybody. And imagine, even at a center of excellence, I mean, one of the challenges is going to be having sufficient resources to offer this to enough people, should many people want to receive it. Um, that's not going to be a simple thing for anyone, given how prevalent Alzheimer's disease is and the fact that it's being diagnosed earlier and earlier, I think, these days.
Dr. Caselli, many thanks for sharing your expertise about the diagnosis and treatment of Alzheimer's disease with Medscape.
My pleasure. Thank you.
I'm Dr. Andrew Wilner, reporting for Medscape. Thanks for watching.